I'm Professor John Eastwood from Sydney University and UNSW. I'm a paediatrician and doing work in the perinatal substance area with Julie and others. It's my pleasure to chair this session this afternoon and welcome Deborah Schofield, who's the Director of the Centre for Economic Impacts on Genomic Medicine at Macquarie University. And Deborah's going to talk to us today on genetics and economics, the hidden cost of substance use in pregnancy. So thank you very much, Deborah, for joining us, and it's over to you.
Thank you very much. Before we get started, I would like to also introduce Evelyn Lee. So she's a research fellow with our centre. Evelyn, I don't know, there you go, you've got your picture on there. So I just wanted to introduce Evelyn because we've gone on quite a few projects now with Julie and John and others. And so I just wanted you to see her face and know who she is. And she worked on the SACS project, and if we're successful with some of our other grants, she will be the postdoc on those. So just wanting to let you know that there's another member of our team who has a really good background in reproductive health and substance abuse. So from her prior life actually at UNSW. And so, you know, lovely opportunities for us to work together. But going on now with the presentation, let me see if I can get it into full screen mode. Okay, can everybody see the slides as a presentation now?
No.
Yeah, we can see it now.
Yeah, I can.
Oh,
yeah,
yes,
looks
now
good.
we can.
You can. Okay, so it might have just been a bit of delay. Okay, just making sure that that's moved on for you.
Yeah.
Great. Okay, so we're good to go. And just let me know if there's any difficulties because, of course, I can't actually see most of your faces as I'm doing the presentation. So just giving you some background in terms of the context in which we find ourselves. So for economists, the policy context is really important because our role is often one that intersects between the clinical world and that of policy. And the really important thing at the moment is to be aware that we're in an environment of fiscal restraint. And that was certainly true before COVID hit. But now it's even more so. So the likelihood is that we're going to have $1 billion or more in debt this year with continued losses to the budget. So it's really important that we make our economic case because public resources are going to be even more scarce than they have been in the past. And the issues around fiscal restraint and sustainability have been quite important now for about 20 years. And I worked on work in the Treasury called the Intergenerational Reports. And you can see there the way health is a growing proportion as well as aged care of GDP. So it's certainly on the government radar. So while our governments want to provide access to new therapies and new innovations, there's always an eye to the bottom line. And this has been, prior to COVID, largely driven by the aging of the population. So what we found in 2002 was that there was more than 5 people of working age to support everybody aged 65 and over. But from 2042 onwards, there were half that many, about 2.5 people. And so this, these drivers in terms of demands on the budget have actually created a situation where when people ask to have things funded, particularly by the Commonwealth, they're actually looking for what's called offsets. So previously people had a good idea, such as the ideas within your team, you'd gather your evidence with your research and you think you'd like to introduce it into the health system. And if it costs money, you may go to the Commonwealth or state governments, and if on balance they found that it was both effective and cost effective, then it would automatically be funded. But now there's a new step called offsets or revenue neutral, and that means that government actually wants to find something else to cut to fund your new idea. And initially there were quite a few things they were happy to cut, But now that they've been doing that for quite a few years, it's harder and harder to find those offsets. And so our economic arguments need to be all the more persuasive. So the message to take from this that will come through this presentation related to genomics is that if your intervention is going to generate savings, not just in the Department of Health, but potentially in other portfolios such as education, the NDIS, human services and so on, it's really important to collect that as you go. Because if you go with your case and you're told, sorry, but it's not really cost effective enough, you don't want to have to go back and retrospectively try and gather information because it lacks credibility and is considered to be driven by bias. So let's have a look at how that message is flowing through our work on genomics. And then I'll talk about some opportunities specifically related to substance abuse in pregnancy. So when I began working in the field of genomics, what we had to ask ourselves is, were the methods we were currently using sufficient, or was there more that we need to do to value medicine at the frontiers of research? And the first thing is to ask ourselves, what should we measure? And as we began to develop some profile in this area, we were headhunted from the University of Sydney, where I'd been for about 15 years, to Macquarie University to set up a centre on the economic impacts of genomic medicine. And that's where we've been for the last 3 years, although of course we still have many collaborators. In fact, most of our collaborators are at Uni of Sydney, and also UNSW. And despite the fact that those two universities may see themselves as rivals, I actually have as many collaborators with UNSW as I do with the University of Sydney. So they're both very important collaborative organisations to us. So first of all, summarising, what have we found in terms of economics and genomic medicine that can give you an idea of some of the work that we've done so far. So one of our first papers that we published was related to looking at childhood syndromes or suspected childhood syndromes in children aged 0 to 2. And so this was done with some colleagues in Melbourne, and primarily it was focusing on diagnostics. And what we discovered, and what was very influential and contributed in part as some of the economic evidence related to the recent MSAC application and in fact funding of that Medicare item, was that what we discovered was that if you used whole exome sequencing instead of the genetic testing that had been done on an individual panel basis, it actually cost 4 times as much to use the old technology as to use the new technology. In the end, we went with the second from the right case. There were some tests that people felt that we needed to keep including. So it didn't end up being cost saving, but it ended up being quite inexpensive for each diagnosis that was obtained. And this wasn't the only study that we did. We did several others where there were even more striking results. So in a study with colleagues in relation to epileptic encephalopathy, what we discovered was that there was a cost saving of about $5,000 by using genomics, and that the standard pathway actually cost 10 times more to obtain a diagnosis. Similar with neuromuscular disorders, but this was a panel, and that was because there's an Australian panel that's updated on a very regular basis. And so most of the diagnoses that you get with an exome are picked up on that panel. But it was 4 times more to use the old pathway than the new. And the cost per diagnosis was actually reduced from 22,000 down to about 7,000. So despite the fact that it costs money to use genomics, what we demonstrated is even just looking at the diagnostics, you can in fact save quite a large amount of money. And that's even true as more and more genes and related variants that cause genetic disorders are being discovered and published. And so if you go back and you reanalyze the data 18 months later, where you haven't had a diagnosis, you can still end up saving money rather than persisting with other forms of diagnosis. So that work was very compelling and very interesting, but it still doesn't tell us all the things we really need to know in terms of the world of economics. And our colleagues Sagoof and others from the UK have put this very nicely, and that is that government doesn't really have a threshold at which it's prepared to pay for a diagnosis. It normally thinks about funding in terms of quality adjusted life years. That's the recommended metric. It's used in Australia by MSAC and also NICE in the UK. And so what they want is to demonstrate that people's health improves and they may also have greater longevity. And so our current studies, which were only on the diagnostics, didn't have that information embedded in it. So what we needed is we needed more information about health outcomes. And it wasn't just about the children who were presenting in the clinics, but also about future offspring, because if one child in the family has a condition, future offspring might also be at risk. So what we needed to include was the cost of additional treatments. We needed treatment outcomes. We needed the cost of cascade testing. We needed reproductive costs if people used IVF and PGD. And we also needed information about reproductive outcomes. So to do that, we then continued on with our study and we followed up those same children with the childhood syndrome study. And we found that for one child, they didn't have to continue to be hospitalised. They had alternating hemiplegia, and that was a cost saving, although it didn't improve the health of that particular child. There was another child who had an additional 12 months of life, although still with severe disability. And then there was a child who was identified, had a thiamine transporter disorder. Now, this disorder usually results in both physical and cognitive deterioration. However, there's a very inexpensive treatment, which is a thiamine supplement, a form of vitamin B. And that stabilised that child so that their disability did not continue and they continued to gain quality of life that would have been lost because they would have continued to deteriorate and eventually have passed away in adolescence or, if they were fortunate, young adulthood. And then another who no longer required transfusions. So when we looked at the cost effectiveness and we looked at those outcomes we just looked at, it cost $27,000 for each quality adjusted life years gain. So this is the incremental cost effectiveness ratio. It's the additional quality of life and additional years of life and what it costs for each of those. But the important thing is if we took into account the impacts for their relatives, there was a child that was a sibling of the child with the thiamine transporter disorder. They had the same condition, but they were not yet symptomatic. And so they were able to intervene with that child before symptoms appeared, and that child, to our knowledge, has continued to be asymptomatic. And it makes it almost twice, well, more than twice as cost effective once you take account of that additional member of the family. Now, the other thing we found was that once people had a diagnosis, they felt free to go ahead and have further children without worrying about that condition recurring, if it was a de novo case, so it wasn't something that could be inherited from the parents, or they could access IVF and PGD if they had a diagnosis, and they could select the embryos that were affected for implantation. And as you can see, that is even more cost effective. So the important thing here in genomics is you have to think beyond your individual patient to other family members and even to future offspring. But even so, we still haven't met the usually required hurdles for cost effectiveness analysis. So usually we need to take into account what happens over a lifetime, not just in those early years of childhood, but also to take what's called a societal perspective and ask, are there impacts not just within the health system, but beyond that? And our data was only for infants and young children in that study. And so we have had to think beyond what we did in that study for our future and larger grants. So as you can see, many people, when they talk about cost effectiveness and health economics, they think about the Department of Health, whether that's Commonwealth or state. And in this case, it's the federal department. But if you take a look at other departments, you'll see that the Department of Social Services actually dwarfs the Department of Health in terms of expenditure, and education's of a similar size. So if your intervention is likely to impact on the children's educational needs, their outcomes and their costs, then we should take that into account. And if they're going to be impacts for the child themselves or their parents in terms of welfare or taxation, for example, then it's really important to take that into account, particularly in this current environment where our governments are generally quite deeply indebted. So what we needed is we wanted precise information about individuals, because you might find that there is no two conditions that are the same in a single cohort when you're looking at genetics. It might have an impact on multiple family members. There's a lot of heterogeneity in the clinical presentation as a result of that. And if you want to model targeted therapies, then you need to be able to model different therapies for different individuals. And there may be very large and diverse societal costs. And so we take an approach called microsimulation. It's a method in which we happen to be both pioneers and international leaders, and I'm the health editor for the journal in this field. And it's actually happens to be perfect for this particular type of application, such as genomics. Now, we were doing this long before genomics, and part of the reason I started working in genomics was the great fit between what was required and the work we did. But also I used to be a speech pathologist. So before I was working as an economist, I used to run a clinic, a paediatric clinic with children with delayed speech and sometimes intellectual disability. So this is the sort of work that we do. I have done it in the Treasury and as an academic for a couple of decades now. And it's a very credible form of analysis. So it's used by the Congressional Budget Office in the US. It's used by Statistics Canada, Department of Health in Canada, the Treasury in the UK, and the Department of Social Security. And I've been and presented our work to some of those organisations, the Treasury in Australia, and other important funding organisations. So it's considered to be very robust approach to this sort of work. So we have a number of studies, but I'm going to just show some results from the EPIC-ID study. And this is the application of genomics to intellectual disability. And this work is being done with the GOLD team, Genetics of Learning Disability. And in that study, we are taking account of a very wide range of costs. So the treatment costs, aged appliances, modifications, obviously quality of life, as we talked about, but education, respite care, public housing, even transport costs, relationship breakdown, which leads to poverty, And then we're looking at the person with intellectual disability and their carer and impact on their capacity to work, their income, savings, income in retirement, impacts on poverty, and also, as we talked about before, reproductive planning and even national level impacts such as GDP. So in this particular cohort, one of the very striking things was the mental health aspects for the carers. And so about 30% of carers were assessed as having moderate to extremely severe depression. Similarly, a clinical description of anxiety and a clinical measure of stress, and quite a high number who had a concern that they ought to be assessed for PTSD. And my colleague Nadine Kasparian, who's a psychologist, is responsible for that part of the work. The cohort is grouped across a number of ages. We've actually got about a little over double the numbers that we've got here now, and we're in the process of follow-up. So this is not complete data, but still sufficient to give quite some useful information. Different degrees of disability, range of age groups for the carer. So the first and most striking thing was the enormous cost. So you can see there that the costs per household per annum are about 40,000 to the Commonwealth, about 80,000 to the state, but the private costs are also enormous. And so when we looked at these costs, the first thing that we noted was the health costs are only a small fraction. It turned out that they are less than, so about 95% of the costs are actually outside the health system. Even so, the health system costs are a few thousand a year, and also some quite substantial out-of-pocket costs. But if we looked at the NDIS, this is where you see some huge costs, particularly when people are older and require residential care. And those costs can be in the order of about 80,000 per year. So if we look at where these costs are largest, what we see here is that patient welfare costs over time become very expensive. State government's residential care costs, and for families, it's the lost income of the patient as well as the carer. And in total, what we have estimated is that the total household costs over a lifetime is around about $11 million per household. So this is intellectual disability, which has not been considered a particularly expensive disorder, is actually enormously expensive when you undertake this type of really quite thorough study. And you can see there the costs spread across the Commonwealth state, but large costs related to the patient and also related to carers who often have to leave the workforce to care for their family member. So the cost and looking at where those costs lie, you can see there when children are young, it's the time that carers have to take out of the workforce and welfare costs. They're spending money on things like wheelchairs and other aids and appliances. But as they become older, it's actually the patient's lost income once their parents are getting older and nearer retirement age themselves. But it's also accommodation for people moving into residential care. And as you see here, for patients, the likelihood of being on welfare once they're over the age of 18 is close to 90%. Some of them have subsidised employment for those with mild intellectual disability, but also 70% of the carers are also on welfare. Strikingly, we looked at people's capacity to support themselves and to have funds available for various things like bulky costs that they might need in life. And you can see here that over 20% of people had no savings at all. This was the biggest group. And the second largest was 0 to 10,000. So this is the bulk of people in these groups with quite large savings. With minimal savings. Then if you look at those who can't work, there were a large proportion of people who couldn't work because they were caring for their child. Some had a disability themselves, some were retired, and about a third were working. But interestingly, even the spouse, also about 10% of them would also not work. So the disability in their children was so severe, and sometimes with more than one child affected, that actually required 2 full-time carers, not just one in some cases. And this resulted in quite substantial poverty, and some indicative measures of that was that close to a quarter of families had difficulty paying for their utilities, gas and electricity, and some of the families actually didn't have electricity when the genetic counsellors went to do the interviews, and they could see that they didn't have a fridge and they didn't have the lights to turn on. About 10% of the carers were going without meals, and close to 20% couldn't afford to eat, to heat their homes. The quality of life of carers was very markedly affected. So pain for the primary carer was high, and that's because there's a lot of lifting involved. And so if people are injured, then it's difficult for them to recover because there's often nobody else who can do that lifting in their place. Also takes a large toll on their relationships and as well on their mental health. Now, we had read some prior studies when we applied for this NHMRC grant that said that fathers had little impact on their quality of life. This sounded unlikely to us, and we've demonstrated that that is true. So they too had poorer physical and mental health, and also again that higher impacts in terms of their pain. You can see there with the negative difference in the scores. Also has a really large toll on people's relationships. So about 40% reported being fairly or extremely unhappy in their relationship. And this was also reflected in high rates of relationship breakdown. So we're currently undertaking similar studies to these and putting together the results. So they're in different stages, but we're doing work again with NHMRC grants on genetic blindness, epileptic encephalopathy, both childhood and separately adult cancer, mitochondrial disorders, preconception carrier screening and prenatal testing. And I should add there's another recent grant in terms of targeted therapies for psychiatric disorders. So what can we take from this that might be relevant to the sort of work you're doing related to substance abuse disorders? So first of all, now that we're in an environment of greater government debt, low cost and cost saving therapies are particularly attractive in terms of what they choose to fund. It's important, if there are large costs there to be considered, then such as with fetal alcohol syndrome, that you do think beyond the health system and look at cognitive outcomes and impacts on schooling and subsequent employment, for example, because there might be very large gains there to be measured that are a result of your interventions. And then similarly, that genetic diagnoses and therapies are emerging that are providing breakthrough changes in all sorts of areas, including substance abuse. And so this provides a little bit of information in the next few slides about where there's some emerging opportunities where genomics might become highly relevant to the work that you do and provide us with even more opportunities to collaborate. So first of all, there is potential in terms of quality of life and longevity gains for both babies and their mothers. There's likely impacts on educational attainment, employment, both for mothers and children, but also income savings and welfare dependence. And also, if you follow up and if you model over a lifetime, then those impacts add up. To often millions of dollars per household. So let's have a look at where some of the opportunities are emerging in relationship to substance abuse. So this was an article in 2017. It was a summary article by the editor-in-chief from Human Gene Therapy, and talking about gene therapy for alcoholism and other substance use disorders. And one of the things that the editor noted was that twin studies had demonstrated that alcoholism is the most heritable of the substance abuse disorders, with about 71% of the risk determined by genetic factors. So the downside in terms of the consequence of this is that often this is a multi-generational impact because it's a highly heritable disorder. And as I see in some of the work of Julie and the group, that you are already talking about how the impacts are on mothers and then the outcomes for their children in terms as also as they become older. But there's also enormous upside here, and that's the potential for genetic therapies, because it can have an impact that will then also benefit across generations. So one of the things that they noted was that once you understand the biological basis for substance abuse, then there can be some molecular approaches that can be discovered. And so one of those is the development of vaccines and immunotherapies using what's called vector-mediated approaches. So basically what that's talking about is gene therapy, where something like a virus is used as a way to bring into the body antibodies that are not being produced by the person themselves, and some examples related to nicotine and cocaine. So if we look at nicotine addiction in science translation medicine, again, this is looking at a gene therapy. And so the quite remarkable thing is that often it only requires a single dose. And these types of gene therapies can be remarkably effective. I'm working with colleagues who are currently introducing gene therapy, which was one of the first, well, in fact, the first approved by the FDA for genetic, or a particular form of genetic blindness. And it's potentially a cure, and in fact improves the eyesight of some of the people who've already lost some of their vision. So gene therapies are already making their way into the clinic. And so what we're talking about here is not something fanciful, but something that we are already seeing. We're also seeing it for spinal muscular atrophy as well. So something with real potential, although not yet generally being made available as a therapy, but certainly some good indicators that it may become available for the future. So what was found in this study, and it was an animal study, so it was a mice study, and they found that the use of this antibody shielded the brain from nicotine concentration effects, and that the benefits were seen in terms of reducing the effects that ordinarily seen with nicotine in terms of the cardiovascular outcomes and also the locomotor activity for the mice. So what they were saying is that if that efficacy translated to humans, it may be an effective way in terms of preventing a preventative therapy for nicotine addiction. Similarly for cocaine as well, there was, again, in human gene therapy, another therapy that was using this particular monoclonal antibody. And when that was introduced into the mice, they actually became completely resistant to cocaine. And the conclusion was that it was a novel strategy for cocaine addiction, requiring only a single administration of the therapy, and that it produced passive immunity that didn't require other forms of intervention. Similarly, for alcohol addiction, back in 2017, there was some studies in relationship to a mutation often seen in Asian populations that results in unpleasant reactions to alcohol. So things like facial flushing, dizziness, hypertension, palpitation, but also nausea as well. So, and this results in an aversion to alcohol intake. And so it was thought that this had some potential to be introduced to other people who in fact didn't have the variant, and it may in fact reduce the pleasure that was derived in relation to alcohol addiction. So what you can see was there was a 90% inhibition of the protein expression, but this was only done in a petri dish, so it was done with cell lines. But getting a bit closer to gene therapy, in 2019, there was another study where they discovered that when they increased levels of a particular gene-encoded protein, that reduced alcohol consumption by almost 50%. And so they were then going to have a look in the post-mortem tissues of the, not just of the mice, but they were then beginning to do studies in the brains of people who suffered from alcoholism to see whether the impact could potentially be mimicked for humans. So in summary, that's a quick whip through of our work in relation to economics and genomics. And I wanted to allow some time for questions and, of course, not keep you from your lunch if you haven't eaten yet. So thank you, everybody. I'm going to stop sharing and see if I can get you back so that I can see you.
Thank you very much, Deborah. That was extremely interesting.
It was my pleasure.
Can I ask you more about the impact on carers? Quite apart from I've been doing some work for WHO at the moment around screening in childhood and a number of national guidelines have determined that it wasn't that screening couldn't be justified because there was no outcome, and they had only looked at the outcome.
Screening?
They had, sorry?
Yeah, a genetic screening, you mean?
No, this was intellectual disability screening.
Oh, I see. Okay.
But that there was no outcome for the child, and so they didn't recommend it, and that's having huge global impacts. Recommendations like that from the US Preventive Services Task Force, for example. It seems to me that your broader argument here around the impact on the carers, on the relationship breakdown in the family, the impact of poverty on the family, etc., must have been missed by these reviews.
And I think that is very often the case, and it's quite unfortunate because many people are only interested in looking at the health impacts because that they believe that that's the only part that's important, and it's not until they find themselves in this translational space that you're talking about that it's realized that the consequences of that sort of narrow approach. So you can certainly get it published without doing some of the broader work, but the translational impacts can mean that it's actually very difficult to get traction and recognition for your work. And we find that it's increasing as treasuries become more powerful and more influential in terms of policy, because they see budgets as a single bucket of money. So the treasurers and finance ministers of nations are responsible for a single bucket, which then gets divided out into the different portfolios. And it's a very different perspective to a Department of Health that might not be thinking outside that box until they're trying to persuade the Treasury or Department of Finance to fund a particular proposal, or in these international forums that you're talking about. So we agree that we just feel that these outcomes are vitally important, and as economists, economic outcomes, educational attainment are absolutely critical, in addition to the fiscal implications. So I think it's a very good illustration of why a broader approach is can prove to be really important.
Could I ask others if you have some questions for Deborah, please?
Hi, Deborah, I'm John Davis, one of Julie's colleagues from Boston.
Hi, John.
and really fascinated with your talk. We're actually in the process of conducting the largest trial ever in newborns of whole genome sequencing and comparing that to a targeted next generation sequencing platform that we've developed with Quest Diagnostics. Our preliminary paper in the first 125 babies or so is going to come out in JAMA Pediatrics shortly. But it's remarkable how many of our findings are similar to what you've been discussing. We also have, it's been amazing to us, about a 50% hit rate, finding a variety of disorders. And in our country, in the US, it's similar. That no one wants to pay for these tests while the babies are in the hospital. Even though when we're finding the diagnosis, it's making an enormous impact on the outcome of the babies. So many times, babies don't get any genetic disorder and they're sent home, and maybe later within the next 2 or 3 or 4 years, someone will actually send a genetic test and find what the issues are. But we've been really struck with just the things that you're saying, that we're often making a diagnosis that even the genetics people, 50% of them don't even have it listed on their consult note on the differential diagnosis. We're also finding that the different platforms don't always agree. So they may both find the same variant, but they're really, it's difficult for them to interpret, especially if it's a new variant or there's not much in the literature. So we've really found significant differences between different groups, which we weren't necessarily prepared to see. So I can't go into all the data now, but it's just like you say, we started off doing probands, and now we're doing trios on everybody, finding lots of breaker genes and other complications in the mothers and fathers, and sometimes even based on the diagnosis we make on the babies, we're diagnosing the whole family with conditions that they've had for many years and just didn't know why they had ankle swelling or other sorts things. So, and we are working with Peter Newman and Josh Cohen and a variety of our economists to try to talk about the same sort of thing. So it was very nice, hearing the kinds of things that you are working on, because I think this is exactly what's needed. And yet many of these babies we're finding are negative, and we're saying, well, how is that possible? We're just not looking in the right place, so we don't know how to look, and we don't know necessarily how to interpret the results. So I think there's so much more that we need to do to make these techniques much more powerful and answer the kinds of questions that you're exactly talking about.
Yeah, I'll look out for your paper when it comes out. I'd be really interested to see what you find in your study. We did publish one of our papers in JAMA Pediatrics. It was the older cohort with childhood syndromes, but much smaller by the sounds of it than the very large group that you've got. And I think, and also since it's newborn, it's much earlier. So I would think with yours there'd be potential for again a review for those children and reanalysis, because exactly what you're saying, there are lots of new variants yet to be discovered, and in intellectual disability our colleagues tell us that there's a new variant recognized as calls about every week. And so it's not surprising that there are many for whom you are not yet getting a diagnosis, even if you're getting something that looks suspicious. And reanalysis might increase your diagnostic rate further. But are you doing any work in terms of the long-term impacts for the children in terms of their health outcomes and so on?
Yeah, so we are working with Josh Cohen. We thought the economics, just as you suggest, are and quality of life is going to be very important. One, we'd like to prove to the government that it's ridiculous that they don't pay for these techniques. They allow us to do skin biopsies and MRIs and EEGs and 1,000 blood tests, but they won't pay for the whole genome sequencing, thinking that it's way too expensive, and it's still, quote, experimental. Yet when we find these problems, we stop all the other testing. We know what we're dealing with, and you're right, it impacts not only that child and the family, but future pregnancies, etc. So we are doing 1 year follow-up for the kids and looking at the economic impact and the quality of life outcomes. So it's called the Gemini project. So you certainly can look it up on clinicaltrials.gov and see. And I told Julie I'm more than happy to chat with you more about it offline to discuss it, because we're also quite interested in the genetics of neonatal abstinence syndrome as well. And we published some of the original work in JAMA a number of years ago, looking at, SNPs and the OPRM1 gene. Now we're actually have done some genome-wide association studies and have developed polygenic risk scores, finding really dramatic differences with kids with severe versus milder forms of opioid withdrawal. So part of the problem, and my plea is to try to get some more specimens, because we have about 700 and we're told that's a tiny amount. And it took me 6 years to get them from different studies. So certainly if there's work in Australia that people are doing, we'd be delighted to collaborate.
Well, I'd be very happy to talk offline with you. So perhaps, Julie, if we could work together to arrange a time to do that. I think Philippa, my PA, I can see is on the line, so she can help us to set up a time.
Julie, have you got a
Definitely, we'll
comment
be very
to make?
happy to.
Julie?
John, you're frozen. Yep. Very happy to. I'll send an email after this and hook you guys up together. That's great. Thank you.
Fantastic. And really lovely to meet you, and absolutely fascinating, the study that you're doing. And we believe that having this diagnosis early in life is actually is really important. And so the fact that you're doing it as a newborn screen, I think will yield even greater results than somewhere you're getting, as you say, the diagnosis after parents have sometimes spent years wading their way through the system trying to get a diagnosis.
Could I ask you both, John and Deborah, what would you actually get from testing the infants of parents on opioids, for example? Would there be any utility in that?
Well, one of the things we found is, again, lots of people have used these polygenic risk scores. We're working with a group who has looked at the difference in our cohorts of babies who've developed more severe withdrawal compared to babies with milder withdrawal or no withdrawal at all, and have found dramatic differences in the polygenic risk scores with as few as 350, 400 babies with a p-value of 10 to the minus 32nd. And so again, part of the problem is it's a small number. We really need 4,000 or 5,000 patients. But the idea would be, for instance, that when a baby is born exposed to opioids, we sit and we watch them for 4 or 5 days, waiting to see if they're going to withdraw or not. And when they get really sick, then we treat them. So how foolish of that. If we could look at clinical or demographic risk factors and look at any genetic susceptibility very early on, could we take the lowest risk babies and send them home? So instead of keeping them in hospital or really having to track them very closely for 5 days, could we send them home at 2 days with just nursing follow-up and save a lot of money? And the highest risk kids, could we start them on low-dose opioids right at birth? And then wean it quickly off for a week, and maybe we can eliminate any and all neonatal drug withdrawal.
So that leads me on to another question. I work in the child protection space and was very interested in the findings from the Dunedin longitudinal study with regards to the so-called warrior gene and the impact of psychological trauma on those children, and how some children are resilient to that and other children are susceptible to that. And that led one to thinking about precision public health, so to speak, precision intervention, very similar to what you just said, John, that some of the infants would withstand the abuse they're getting at home, and others wouldn't. And so when you've got limited resources for intervention, anyway, I didn't really want to go there because it's got huge ethical issues around it. But
well, we have published the fact.
What are your comments on that?
When we look at neurodevelopmental follow-up of some of these babies at 1 to even 2 years of age, the babies that have the most behavioral and other psychological disorders are the ones where mothers have had continued substance abuse, for instance, maternal psychological stress, children with a variety of medical problems, etc. So we do know that these adverse childhood experiences, as everyone's calling them now, do place these children at very long-term risk. And I think some of that work has been done nicely in Australia. Obviously, Julie has shown that these children have problems later on in childhood. So there are opportunities to look at these adverse childhood experiences, and colleagues of mine have found that when you introduce positive childhood experiences, that you can overcome some of those.
John, my question was about the Dunedin longitudinal study that found a difference in the allele, so that one allele was providing resiliency to the children as opposed to susceptibility. Had you come across that?
I haven't, so this is quite fascinating.
So this is the 3-generation study out of Dunedin, which I think Duke University has had a lot to do with it from the States. And we're looking at children who are exposed to adverse childhood experiences, but actually there's 2 groups. One that exhibits, as you just said, but another one that seems to be resilient to it based on the expression of the allele. So that's something, John, you might want to look at. Yeah. And that's what I meant by based on the genomics, what do we as public health physicians actually do? Yeah.
John, there's a question from Jan on the chat pane with early diagnosis.
Jan, do you want to ask that one?
Yeah, I can't see the question on the chat. So Jan, if you'd like to.
Oh, sorry, Deborah. She says mother was a carer, no support until NDIS came aboard. So maybe an early diagnosis because of the child. The child is now 35 years old. Early diagnosis might have made life easier.
Yeah, we find that having a definitive diagnosis does sometimes give families access to a range of services. And if there is a network for the specific condition, it also can give them access to support groups to families with similar children with similar conditions. And that's really important for families, but particularly if the condition's rare, because that group might be a global group with not very many people in it. So I agree. I think with the NDIS, having a diagnosis is certainly beneficial, but also potentially access to other forms of services such as support with education as well.
I would also add that an early diagnosis changes things, doesn't it? You know, when you have the answer, we've in some cases withdrawn support because we know now that it's a lethal anomaly, and we haven't continued to do more and more testing to try to figure out exactly what's going on with the child. But we also have done it urgently. We can now, our group holds the Guinness Book of World Records, sequencing the entire genome in 18 hours. So with babies who are presenting with, say, status epilepticus, you talked about that a little bit, you know, we've made the diagnosis of pyridoxal phosphatase deficiency in about a day and a half with some of these babies, where a child was on every anti-seizure medication, including paralysis. They had been a sibling who had died from the same condition without a diagnosis being made. And we sent the whole genome sequencing, finding that it was the enzyme missing that converts pyridoxine to pyridoxal phosphate, which is the active form. And as soon as we gave the baby the pyridoxal phosphate, within an hour, all the electrical seizures just stopped. We weaned the baby off every medication, and the baby woke up and started nippling a bottle like they had no idea what had ever happened. So it can be that powerful. We've even found incidental findings such as malignant hyperthermia with a baby who was about to undergo surgery for a bleeding disorder. And on the way to the operating room, we discovered the gene for malignant hyperthermia and were able to change the anesthesia so the baby didn't die from that. So there's lots of examples where these techniques, as you say, are very powerful, can save lives, change the outcomes, not always, but also letting the parents know what's going on can really change the way they approach their child as well.
Yeah, you're right. I think it's beneficial whether you whether there's a therapy or not. So, you know, in the case that you're talking about, similarly in Australia, colleagues have had patients where they've survived when they were considered to be within days of death in the NICU. So it's, but at the moment, this is not for everybody who gets a diagnosis. It's for a small proportion, but a growing proportion. But for families where you don't have a therapy and where the child has no chance of survival, it does at least give families an opportunity to spend some time with their child rather than being completely overtaken by these desperate efforts to maintain the child's life and to find a cure, and going through lots of testing, some of which that can be invasive and painful. And I remember a colleague in the UK, they did a big newborn study, and they were saying that in their case, they didn't actually have any cases where there was a dramatic change in outcome. Which was disappointing for them, but they did say that parents, regardless, they wanted this information and they wanted it as soon as possible. And they really, they were sort of worried about the ethics, about if in the cases, which in their case was all of them, where it wasn't going to necessarily make a change in the long term, should they wait and not take away hope from families? But the family feedback was very clear. They wanted this information. They wanted it as soon as possible, and they wanted to be able to make decisions based on that information. They did not want it withheld from them.
Well, thank you very much, Deborah, and everybody else. It's coming up 2 o'clock. Are there any last questions? Julie, do you have any comments, co-chair?
Oh gosh, I'm not the co-chair. I'm I'm just a lurker. Thank you so much, John, for looking after this session, and Deborah for speaking, and of course John Davis from the US. Hopefully we'll get to meet up sometimes within this decade, John. I'll send an email and introduce the three of you together, and if anyone has any questions, Deb's just contact me for Deb's email, I guess. Yeah.
Sure.
Yeah.
They're happy to do that.
It's very high quality presentation.